Okay, everyone, we might just get started. Just so that everyone can get out of here at a reasonable hour, because I know there's nights are getting cold and you guys have got a fair way to travel. Hope the food was good. Excellent. So we're really lucky tonight. We've got Tony Lembke and Katie Smith, and David Guest also, who's all eHealth professionals. Is that how I can describe you?
Yes, no.
Enthusiasts.
Enthusiasts.
Amateurs,
Yes.
amateur enthusiasts.
And they're all passionate about eHealth. So, any questions, which I'm sure are going to come out throughout the night, they'll be able to handle those for you. So Tony's going to start, and then we're going to move on to Katie while she finishes her food. So, Tony Lembke.
Thanks, Viv. Thank you. I'm Tony Lembke, I'm a GP in Austinville. I've been, we'll go into the format tonight. I'll give you an introduction to some of the broader details about the eHealth program that the federal government's rolling out and our role in that. Katie Smith is Program Officer in charge of that with the Medicare Local. Will fill in some of the details about the current iteration of the electronic health record. David Guest will add some of his insights for the work he's done with patient registration and other aspects of it, and will act as a resource person. We'll try to make it as interactive as you would like it to be, so feel free to interrupt and ask questions whenever you like. Any hard questions should be directed immediately to Katie. Look, my mother, I was down sitting last night visiting my mother. She's 87. She chose to have a knee replacement about 6 weeks ago against my advice, because what would I know? The operation was a great success from the orthopaedic surgeon's point of view. The x-ray of her knee now is perfect. Before the operation, she'd get her on a walking stick. Now she's on a Zimmer frame and can't stand up without falling over. I noticed she's on a lot of new medications. And I think the cardiologist came and visited her while she was in hospital. She's getting ankle swelling, she's getting short of breath, she gets dilated when she stands up. What tablets are you on, Mum? Well, she's on a little white one in the morning and another one that nice Dr. Burford started. She knows, she saw the cardiologist, it's quite on the ball, but doesn't understand the details of her health condition. And don't we see that a lot, that people don't know what they're on, or what their tablets are, or what their medical problems are, or their medical problem lists are. And particularly, I've been to conferences where the head of health in New South Wales says everyone needs to have an elderly relative experience to understand the problems we have in our health system as far as connected care goes. So the eHealth, everybody knows that that needs to be solved, and everyone knows the solution to that is a repository where some of a patient's medical information can be stored to be accessed by the people who need to know it. And that's a bit of a no-brainer, that we need some way of commonly having people's health record. And in fact, our patients think that already happens, don't they? Because when they come to see you and you're on the computer, you'll know about that doc, because my previous doctor, he put it in the computer, so you'll be able to access that and look it up. Well, I was in the hospital, I know it's in the computer, so you'll be able to look that up and check it, won't you, doc? So they expect that it's already happening. They would be surprised to know just how dysfunctional the whole thing is. And that's in an area where we sort of lead the pack. We're getting electronic discharge. How many people get electronic discharge from Lismore Base Hospital? So people like that?
Yeah.
They're fairly revolutionary, you know, instead of, and they're quite timely, and you can read them, and they're not triplicate. So things like that, we've got messaging. How many people are getting specialist letters back by medical objects or artists? So they're revolutionary. The scanning sucks. So that's revolutionary to be getting, you know, about 50%, I think, of our specialist letters arriving now without needing scanning. Pathology and radiology universally, except for you, Tony, coming down via the computer now. So that's a big difference. That's an enormous difference in the way we practice. So so regionally we're doing okay, and regionally when we travel around the country, other areas are really surprised to find that we're getting electronic discharge summaries from the hospital, because they're a million miles from that. So there's some things that are happening all the time. But as far as the full sense of connectivity, the benefits that are available for the health of our patients and the benefits for us to make our providing quality care for them easier haven't fully been realised. And so the electronic health record is a path to that. Our model of care that we talk about, and you would have... So the model of care that we talk about, as far as connecting care, as you know, and we've talked about this, at the centre of the health system is the patient, supported by their carers and families. with an ongoing relationship with a particular practitioner who's their GP over time, and that all the evidence is that the long-term relationship with a particular person is where the efficiency and effectiveness of the health system comes from. That person is supported by a practice team of nurses, care managers, behaviouralists, administrators, practice managers. So we've got the home and the medical home. And then we've got the community services, which are dietitians and diabetic educators who don't work in our practice, and community nurses, medical specialists, pathology and radiology providers, community pharmacists, and other community organisations such as Meals on Wheels and EACH packages and all the in-the-home care packages, which is the community services. And the final layer of the circle is the hospital services. And we know that care is delivered the closest you possibly can to the patient is the most efficient and effective care, and preferred by the patients, and our patients have preferred experience where it's more comprehensive and whole person. And out here you get more specialised disease-focused care. So we know that when patients have receiving care, they may be receiving it by a team. And in our model of care, we want this team that's the GP and the family and the patient and the care manager at the practice and the medical specialist and perhaps a local physiotherapy. We need to know some sort of informational consistency about that patient. So they know the patient's medical problems, they know their medication list, they know their allergies, but also preferably know the goals of treatment, the targets that we're after, how they're achieving on their tasks, the actions that are required of each person. So the ideal system, patients will be able to identify their care team. Their care team will change and adapt. It may end up in hospital as they get sicker, and then it will contract again. There'll be a core component that stays the same and the rest of it moves around depending on their acuity. When we have the complete system, it will feel to a patient that it's all joined up, that they're not filling in forms all the time, telling the same story over and over again, and that each of the person who's part of that patient's integrated care team understands the patient's history and records and has access to the information they need to best care for them. So that's the system that we're trying to build. So 10 years, 20 years, how long down the track is it going to take to get to that stage? I don't know. It's a complex system to try and develop, and the first step now is the PCEHR, which was announced, recommended by the Health and Hospitals Reform Commission, the Christine Bennett report that came out in 2009, and was funded as part of the health reform, the government's response to that in 2010, and they put $450 million into having this available and ready for patients by July the 1st, 2012, which was 3 weeks ago. Legislation had to be passed through Parliament. That was a complicated process. It got through in the last minute last year to legislate for that. There's another key aspects that had to pass legislation, including having a unique identifier for patients there, IHR, the individual health identifier. Individual health identifier for patients was passed through Parliament. So a lot of key steps had to be passed, people brought on board, consultations happening to get to July the 1st, 2012. Not a great deal of fanfare 3 weeks ago. It might have slipped past without you knowing it. And I'm sure that was intentional, because there's a number of services that aren't ready. Now Katie's going to talk about what's going to be happening in the iterations to come. And I think it's important that we remember, therefore, the journey that we're having, where patients can have informational consistency, integrated care teams, everyone who needs to care for that patient having the information available to them when they need it. So the PCEHR that we're going to talk about tonight is not that, but it's a first step. And without all the investment in consultation, both with clinicians and community, and IT people and the government, we wouldn't be taking the first step. So it seems like an enormous investment for that first step, but that's the way these things always work. In fact, with any IT program, you expect them to not reach dates, not reach budget, and you're surprised if they even work half the time. And so the fact that something's happening is good. Could it happen faster? That would be better. And David's got a lot of theories about where we're up to and where we need to be, and the progress we're having. And you might talk about that, or his excellent article by David about that. But we should be happy that the government or the health community as a whole has made a commitment to what everybody knows needs to happen at some point or other. But we're going to talk about where we're up to, and we're not up to here. We're taking some very small steps. I guess the model, perhaps if you see it as like the App Store where you get your apps for your broken iPads. So what we're building is, so for a piece, so to break it down, the EHR is the electronic health record, and the PC was an invention of the Health and Hospital Reform Commission, stands for person-controlled electronic health record. And that means that, and Katie will talk more about this, the person-controlled bit means that they control who can access their record, and they control what goes in it, and who can access what goes in it, which is enormously more complicated than just having an electronic health record. The PC bit, the person control bit, makes it a much more complicated bit of IT engineering. But that's what came out of the consultations with the consumer groups that they wanted, and there's some appropriateness about that. But with my records going up, I really would want to know who was accessing it and what was in it, perhaps. So we could talk more about how all that works, and we would do so. So that's the person-controlled electronic health record. I notice when you register now, they're calling it for short your eHealth record, which is much less of a mouthful than PCEHR, your eHealth record online. So Katie will talk a little bit about what you can do now, because you can all, has anyone got one? David's got one, Katie's got one. So you can get one now. And if you look it up, what's there?
Not much.
I'll talk about that.
You're going to show that. So not much there. So the first thing that, so there's been a lot of consultation about what should go in a PC. But if thinking about the App Store, it started off with nothing in it, but it did have some basic fundamentals, which means that with the App Store with Apple, you could log onto it, which is the first thing, and you could, by logging onto it, you're saying who you are and identifying yourself, and the fact that you've got a credit card that you could pay for the stuff you're going to buy. So the App Store provides a framework for all the apps, and then people develop different apps that people can download. So the PCEHR at the moment is just a framework, and it doesn't have much in it. And they can see different apps that they're going to roll out over the years, and the first app that they're going to roll out is a shared health summary. And that's of enormous relevance to the general practitioners and the general practitioners, to all of us here. So the shared health summary is a curated document that contains the patient's medical history in the sense of current problems and past history, their medication list, their allergies, and their immunisations. So that's a shared health summary, and it's curated. So that means curated has two implications. That is, one is a number of implications. One is that the patients nominate who's going to be responsible for their own shared health summary, and that's one person. Most of the time that will be a general practitioner, but it may be a mental health nurse or an Aboriginal health worker, remote area nurse. There are some circumstances where it's much more appropriate to be somewhere else, but 90-something% of the time, the general practitioner is responsible for curating a patient's health record, and the patient nominates who that individual is. So it's not a practice, it's an individual provider. And that provider then is the one who can put their shared health summary up in the PCH part in the shared health summary app, if you like. And only that provider can do that. The patient can't do it, and the hospital can't do it. Only that person. So that's step one of curation, is you have to have a curator. Step two is that the curator decides what goes in it, and that where we come to issues of the quality of the data in our local systems. So a shared health summary implies that on our local desktop systems that we have accurate information about a patient's current problems and past history. And when we go through them on an audit, we know that we don't. We know that there'll be patients who have had very significant events in the past that aren't in our summary list, and we have patients who have got diagnoses in our summary list that they actually don't have that condition, but it hasn't been modified or changed. And so some of the work involved in being a curator is sorting out what a patient actually has, who they are and what they've got. It's a bit like when you're registered at the hospital doing a discharge summary. That's when you actually find out what the patient was in hospital for, isn't it? When you go through and work it all out, that's when that's what that was all about. So the shared health summary is sometimes where you just find out everything you can about that patient and get it accurate. So doing a shared health summary will be a general practice job. That can be assisted, the general practitioner can of course be assisted by their practice team or their practice nurse. And you can imagine if you're doing your chronic disease management clinics or your EPCI numbers, that would be a good time and the right sort of patient to do their shared health summary and make sure it's up to date. So the shared health summary is curated in the sense that someone looks at it and decides what's in it. So it doesn't mean that every reason for consultation is in the shared health summary. Because sometimes when we write to a practice for their past history, you get earache, repeat prescription, urinary tract infection, all sorts of things that don't really belong in a shared health summary. No one's prescribing what a significant problem is. You work that out yourself from your knowledge of medicine and experience and what you would like. So part of our first job is to clean up our data to make sure we have accurate shared health summaries about the patient. The other thing about a curated shared health summary is, so we need accurate health summaries on our computers, and that's our job. The shared health summary, as opposed to our local health summary, needs a patient input as to what they want to share. So I may not want to share the fact that I had a depression, or that I had an abortion, or that I had herpes. I'll share that with you that I had it. No. but I may not want to share that in my health summary because it may not be relevant. I may decide that's not relevant and I don't want people to access that. And so the shared health summary is not just a health summary, it has a patient input as to what goes in it. And so therefore, when you're doing a shared health summary, it's the time. That patients have been doing them. We've been doing this as part of the eCollaborative. It takes time to do it because you have to use your brain to work out what belongs. You have to ask the patient, is this complete and accurate? And you also have to ask the patient, is this what, are you happy for me to share this? So it's not an automatic thing. The shared health summary is not automatically generated out of your software systems. Part of it is, but then you have to change that. So the shared health summary is the first app going to the PCEHR. So general practice is providing all the initial benefits of the PCEHR. The other apps will come on stream. So when can we start uploading shared health summaries? Well, if a patient has registered for a PCEHR and we know what their IHI is, and Katie will talk about that, individual healthcare identifier, and we've got our fundamentals in place, which means we've registered for the PCEHR system and have the appropriate identifiers, then we can upload a shared health summary when our software's been updated to allow that function. You can't do it through a web browser or by ringing up. You can only do it through Medical Director, Best Practice, or Genie, or whatever your software program is. So if you don't have a computer to manage your patients, you can't participate in the PCEHR. But you can't. So none of those software packages at the moment can do that. The timeline is probably the October 31st, when those updates will be made available to general practitioners. So if you've got your fundamentals in place, which we'll talk about, and your patients are registered, and you're registered, October the 31st, if you upgrade Medical Director, or that was a bad example, Medical Director may be well after that. The other practices, the other programs have agreed to October 31st. HCN, who run Medical Director, haven't agreed to anything yet, so that may be a delay on that. But it probably, so they say October 31st, it's an IT program, who knows when it will be, but it will be sometime, it won't be early, it'll be sometimes after October 31st that will be able to download our. So you get the software that we need to upload it. And then it's pretty straightforward, everything being registered. It's a click button, one button. So on the best practice screen, here's a button, click it. Here's the shared health summary produced. Are you happy with that? Change it or not? Another button, up it goes. So the actual, and so can I demonstrate that? No, because nobody's seen that yet, but this is what they're telling us it will be, and this is what their demos look like, and that's what the vendors have been paid to do. So when it comes to that stage, once you've curated the shared health summary, have your fundamentals in place, it's not a difficult job to upload it. So from the GP's point of view, it's a clinical job to curate it and a button. It shouldn't be a technical job to get all the things in place. That may be their job, it may be their practice manager's job. And we'll talk a little bit about some of the fundamentals you can start doing now to be ready for that time. What are the benefits of this? There are clear benefits for the patients eventually, when people get used to looking at it. So when there's only a few, there's 1,000, now there are 4,000 people in the country now who've got a PCEHR. None of them have a shared health summary. The hospital is not going to start looking it up every time a patient comes in to see if anything's there for some months or years, because they'll get sick of looking it up and there'll be nothing there. So, and the patients, are they going to look it up? Well, the GP's going to look it up, not much, because we put it there. We know it's there, it's already on our desktop, so what are we going to look at it for? Because it's only what we put there. If they're David's patient, if they're my patient and very sensibly give me the flick and go and see David, then he'll be able to look it up and see what I thought, and he can decide whether to add that to his system or not. So that's a use case that happens, particularly it may be useful in the coastal towns where there's a lot of tourist traffic or the grey nomads coming through. That may be a really useful resource to be able to look it up. If their home practice, their curator has uploaded their shared health summary. So the benefits will take a while to flow. So there's work involved by us. And what benefits do we get out of it? Well, at the start, we get a feeling of a good feeling inside that we're doing the right thing. We can be proud that we're pioneers in the eHealth space, and where the bus is going to, we've made the first step. So that's not unreal. I think that's not unrealistic. I think that's important, that we feel like that we're part of the pioneer group. We've made the first step. This is the first step, knowing that benefits will flow. Money-wise, is the government going to pay us every time we upload a shared health summary? The AGPN position paper on this is yes. There should be a SIP payment or a MBS item number. If you upload a patient shared health summary, that implies you've curated the record, you've discussed it with the patient, you've got their consent. That's work. We're not getting benefit out of that, so that should be we're GPs are pretty cheap. You don't have to give us much, but give us something, and you'll find the volume will flow. No, they've said there's no SIP or MBS item at the moment, despite myself and other people keep telling them that's what's going to drive the volume. The EPIP coming out, so they talked about this at a conference this morning, so I guess it's public, that you will have to have the capacity to the software and the fundamentals to participate in the PCEHR to claim the EPIP, which is between $20,000 and $50,000 per practice, and a few other things as well. So you'll have to be able to do it, have the tools in your place, which is not that hard to get the EPIP, but you won't actually have to upload any shared health summaries. I don't know how they're going to drive the volume, but we will get a good feeling inside that we're doing the right thing. And eventually things might change. So that's the first app, the shared health summary. So from October, some of the other apps, they don't talk about before, the PBS information. So you've got to look up and see what medications have been dispensed to that patient, which could be quite handy. Because, however, that's an incomplete record because it doesn't include private scripts and it doesn't include some medications that are cheaper than the threshold. You'd be able to look up the immunisation history, the ACIR stuff will be part of their shared health record. I mean, part of their PCEHR from October the 1st, they say. So that they'll start to populate automatically, so that'll be useful. You'll be able to, and then they're talking about event summaries. All right, it's fantastic, isn't it? So event summaries are things like a hospital discharge, or if they see the physio, they can send up an event summary saying, I saw them today and fixed their shoulder. So event summaries may start to flow to the PCEHR, but nobody's really worked out how that's going to work yet. But clearly a hospital discharge summary would be a useful piece of information. Event summaries will eventually include things like X-ray reports and pathology uploads. But how do you do that? We don't want every pathology test to have that while they're in ICU in their PCEHR because it'll just fill it up. And so people will stop. So technically, none of this is that hard, but clinically, is it accessible, easy, usability of it, how easy it is to use, is it going to make it better? Are we ever going to bother looking it up, or is it just going to be too clunky? Everyone is cognizant of the fact that it needs to be easy to use, relevant to the people who are going to use it clinically, if it's going to be used to make a difference. So there are NETA, which is National eHealth Transition Authority, which has been given the job by all the governments in Australia to do this, has a group of clinicians who advise them on making it useful. It's always a fight, isn't it, in all these things between the clinicians and the IT guys about what happens. And so the clinicians don't always win those fights. Did you have a question?
I just was asking, once a person gives permission for the PCEHR and we, the curator, upload it, all these others automatically flow, or do they have to give permission for each of those separate things like apps, like the PBS and immunisation? Do you know how that works?
Currently, when you actually register for the PCEHR, having done it on the phone, they ask you if you give permission for MBS, PBS and ACER information to go up in your record. And it's the same online, I believe, although I haven't been successful trying to register online.
So people can pick and choose.
They can decide. And with my experience on the phone, there was no coercion or discussion about whether that was a good idea or a bad idea. I was just given the choice. Therefore, there was some expectation that I would understand what PBS data and MBS data was. So it's bearing in mind, it's all these things, as Tony says, we're only 3 weeks in to a plan of at least a decade. So it really is to baby steps. So it's going to take a little while, I think, for some of these issues to be ironed out.
The other app that's available now is the Patient Health Diary, where as a patient with your thing you can write in, I feel good today, or I took my medicine, or I've been to, my blood pressure's this, and you can do that now. But that's just for you. And so the GPs, when they look it up, don't see that, and so you don't feel that you have to look it up, or otherwise you're missing some of them, medically or legally. You're not missing part. They don't show that to you, so you can't see it anyway. So you can't feel that you're going to be sued for not looking it up, which is why they don't allow it. It's just for the patient to put their own notes.
As a curator, do you have any legal liability for uploading a record that you know is incomplete? So they've got AIDS or active FC, you don't put it up there, and another health worker contracts it because you haven't put it on?
Well,
Can they sue you?
The agreements to participate in the program have been given to us in draft form on a number of different iterations, and they've been onerous. All the responsibility has been on the local doctors, and we exonerate the federal government from any mishap that may occur to the patients as a result of our participating in the program. And that was the first one, and the second one was somewhat better. So, but the final document of that hasn't been released because, and we can't do it yet anyway. But so the medical defence organisations have been involved quite heavily in sorting out how that's going to play out. But what will happen is, no, you won't be. It'll be an accepted part of the PCEHR that it's not necessarily a complete record of the patient's care.
And I can refuse.
You don't have to. You don't have to participate in the program at all, and you don't have to agree to curate it on behalf of the patient. So Steve Hambleton gave a talk at the press club yesterday, and he said if a patient wants him to withhold information, he will refuse to do the SHS because he would feel that was not complete care. Personally, I'm a bit less bolshy about that. I think if someone doesn't want their abortions to go up or there, I think that's up to them personally. But
that's not usually an ongoing problem, though, is it?
No, but that's right. So HIV may be one that you, but if you have HIV, so I don't know. If you have HIV, most people would want treating physicians to know that because it's so relevant to their care. But, so the actual document that we sign is not in our hands. That's there are a number of objections to the PCEHR participation, and the legal liability one is one of the keys. And so everyone's aware of that and they know that they need to sort that out or it just won't fly.
So is there a box to tick saying you know this is incomplete?
No, they used to have that. So they've tried lots of different things as they run it through. So they used to have like your record and there's a little lock up here or a little treasure chest that shows there's more information but it's hidden from you. But at the moment, if they took that away. So there's no indication when you look at a patient's PCH, because there is in the PCEHR, you can lock some information that only certain people can access it. Because there's 2 levels of access that you can provide as a patient. So as a patient, when you register, you can say, everyone at Austinville Clinic can look at the record, but no one else. Or you can say, everyone in the world can look at it except those bastards at the Austinville Clinic. So you can say whatever you want, and you can give certain people access. But there's no indication if I look at it whether I've got full access or incomplete access. And part of that reflects, and they say this reflects exactly what happens now. So if I go into A&E, I can tell them whatever I want. They've got no way, I don't have to tell them I've got AIDS or that I had this or that. It's my choice as a patient. So it actually reflects, and you don't know whether I'm hiding stuff or not. So it actually reflects current practice to have it in that way. And this is what the consumer groups said when they consulted with them, and I can see some logic in that. So if you're unconscious,
I'm being coerced into something that's inadequate. If
you're
I'm backing that, that's
depends how much you value the completeness of the record against patient's choice to see who. Because the patient, when they see some, can always tell them. if I go and see a surgeon and I've hidden AIDS, I can always tell them. If I'm unconscious, there's a break glass button, so the accident emergency doctors, or whoever needs it, can see the whole record if they need to.
Because you're saying it's not on the record.
No, that's true. So patients may choose to not have it there at all, or they may have it hidden.
But like you say, it may be to their detriment if they don't give that information out anyway.
But the experience, that's right. And the
And you
experience
should be
is,
treating everybody as if they have anyway, using universal precautions.
that's right.
Yeah.
The experience has been that no one ever hides. The experience is that 99% of people allow access to anybody and don't care less what you put on the record. And that's been my experience. We've been running sort of a pilot with the Wedgetail program, asking patients how they give a consent. I tell them that, look, we'd keep it as secure as we can, but the banks get hacked, Yahoo gets hacked, the Department of Defence gets hacked, so it's like quite possible that they'll hack into it and your records will be displayed for everyone to see. And they go, yeah, where do I sign? So there are very legitimate privacy and confidentiality concerns, but for many people, they see the benefits outweigh the risks, and I think that's probably a fairly legitimate position to be on. We have to think what we would want on our own record. It's easy in the abstract to think about patients, but when it's our record, it seems a bit different to me what I might put up there. So we need to. So the set up to respect the rights of the patient to tell their own story. Really. And as I say, that does reflect what happens now.
I think the difference though is, Tony, that if there is some medical and legal responsibility being thrown back to us, it seems like we need to know what that is prior to this October 31st magic date. So are we going to know when the next document?
Yes, when the next document comes out.
Yeah.
The college and the AMA and the AGPN have been providing feedback to the department. It goes back and forth. The department's actually keen to get it right because they know that the whole success of the $450 million they spent will stand and fall by the success in getting a volume of shared health summaries. So I suspect it will say that you cannot be sued for withholding information that a patient has requested you to withhold. In fact, you can't be sued for not looking at it. There's no obligation of you to look at it when you're treating a patient. So if they're allergic to Moxil and you don't look at it, and you haven't looked up there, apparently you're protected from that. So they're trying to work it out to make it a workable probe. But so yes, we'll get the AMA are bolshy, so they go over it. We'll have reports about whether it's safe or not, medically or legally, for us to participate before then, I imagine.
So the patients can actually say who accesses it, you're saying?
Yes.
How do they do that?
Well,
Remotely, do you know?
Well, you can't actually do that yet. So that's... Katie will talk about the 3 ways you register for a record, and part of that, you can just ring up and tell them who you want to access it, but they can also do it online.
Is there anybody else who would say who can access it or can't access it?
Only the patient.
So in other words, any of the Workers' Common Insurance Act people could eventually, just by the bottom of the form on the insurance thing, access their entire health.
No. So there's protections as to the uses of the... It's only for primary... There's 2 other things about the Katie I mentioned. One is it doesn't replace our own existing health records. It's just the incomplete part of our record. So our own records on our desktop are the point of truth, and this is just a snapshot of part of that. So it's not to be used as your only medical record system. Another thing is it's only for primary use of patient care. It's not for secondary data trawling, and it's not accessible it's against the law to use it for any other purpose apart from clinical patient care. So if a pharmaceutical company, someone got access, or a workers' compensation doctor looked it up, not for their clinical care, then that's against the law. And there are quite onerous fines for that. Every access to a patient record...
If they get the patients to sign something saying that they can have complete access to their record.
Don't know.
Because people don't realise that's what happens.
I think the legislation...
Workers' comp form now, and they're starting now to access everybody's entire record, not just about that injury.
Yeah, the legislation is quite clear about that, but we can clarify that. So at the moment, yes, that's right. So it's not to be used for research, it's not to be, at the moment. And patients have to give particular consent to allow other uses for their data, and that hasn't been sorted out yet. Because you can imagine if it's got every diabetic in the country in there, what a valuable piece it would be for population health planning. So or for research or for improving the care we deliver. So there are secondary uses that are perfectly legitimate that will make an enormous difference to the way healthcare is delivered, and we need to work out how to consent for that and use that. And that's sort of down the track of where the bus is going, very much so. So that's a whole general background of the PCEHR, and there are lots of questions that arise out of that discussion. I might hand over to Katie to run through some of the details of the foundation. Thanks, Katie.
Thanks, Tony.